Ma'am, we are live now. I
Okay,
will
okay.
be starting with the introduction and welcoming, ma'am.
Shall I play my video? Is it necessary? No need, na?
Ma'am, it would be better if everyone gets
Okay,
to
one
see.
minute. 1 minute. थोडं व्हिडिओ पाहिजे ना. आई एकच मिनिट थांबतीस का? एकच मिनिट मी स्टॉप प्रेझेंटिंग करते. मी माझं फाईल एक दाखवून द्या. आज एक सगळं तुझं करायचं होतं का म्हणून मला माहिती तुला. एक 2 मिनिट नंतर बंद कर. हॅलो स्टुडंट म्हणजे हॅलो.
Yes, ma'am, you are visible.
हा हा येस येस हा येस हॅलो
Ma'am,
एव्हरीवन.
can you shift this screen to the slide presenting screen?
दिस स्लाइड टू प्रेझेंट स्लाइड इकडे काय इकडे ही स्लाइड काय ही स्लाइड इकडे घ्यायची हे माझं यायला
PowerPoint presentation, PPT. It's right down there, orange one.
नाही तर दोन्ही नाही येत. थांब एक मिनिट चेक करतो. काय तुमचं प्रो काय म्हणायला त्याला हे फुल स्क्रीनवर यायला पाहिजे
No,
वाटतं.
ma'am, it's visible. Just click on the orange PPT
हॅलो.
button. Yeah, ma'am. Just click on that orange button, PPT button. It's there. It's down in the toolbar.
Okay. Yeah. Oh, you're just telling to present it again. Okay, fine, fine.
Yeah,
Oh,
yeah.
yeah.
Also, ma'am's camera is off. You just switched it off.
Yeah, like when she is presenting, obviously, like she'll be explaining, right? So, is it necessary for the camera to be on?
Okay, okay. Then later during question and answer, I need
Yeah,
it
like
to be on.
during the Q&A, she'll switch on the camera. As of now,
Yeah,
she'll just explain. Yeah.
yeah, fine, fine. Okay, ma'am. Can we start with the session,
हा
ma'am? I
हा
will
येस
be
येस येस हा
introducing about the answer and welcoming you, ma'am.
हा
Okay.
येस.
Hari Om, everyone. A very warm welcome and good morning, and welcome to the ninth session of Higher Anatomy, a lecture series for the first year BMS students. The exclusive sessions will be taken up by the eminent speakers of anatomy across the country for a period of 27 days. We started from 23rd of June and will be running up to 17th of July. Before starting this session, let me introduce you to Jignasa. Jignasa is a pan-India platform of Aish fraternity led by the student community of Bharata and was initiated by ABVP in the year 1998. Its motto is Learn Aish to Practice Aish. It involves empowering Aish students from campus to community, bridging the gap between Aish students and policymakers as well as administrative authorities, connecting every aspect of Aish including students, academicians, practitioners, scientists, industrialists and hospitals all under one umbrella. Think globally, act locally. In last 2 decades, our efforts were to strengthen the Irish education system and boost confidence among Irish students. Jignasa initiated various programs in different parts of the country, from the grassroots to international platforms, through discussions, study circles, seminars, workshops, and conferences. Let me list a few initiatives undertaken by Jignasa, starting with study circles, lecture series on specific topics, free medical camps, social health status survey, hands-on training workshops, conferences to explore and learn unique aspects of Ayurveda, interaction with eminent Vaidyas and academicians, brainstorming sessions with eye stalwarts, policymakers, and key stakeholders of eye systems, National Arogya Expo and International Conference, national level seminars, medicinal plant visits, pharmaceutical visits, agitations for the demands of eye student community, private internship program for interested students to learn with acharyas, interaction with traditional healers, and visits to explore regional flora, online mock tests, social awareness campaigns on various issues, campaigns for the promotions of various concepts Ayush system for social welfare like Swarna Brindu Prashana Camp, Ashtoshatatari Yoga, Group Surya Namaskara, and other competitions. Free healthcare assistance to people through local governing bodies during natural calamities and accidents, and many more were provided by Jignasa organization. In our yesterday's session, more than 300 students joined for the live session and asked their queries regarding the subject and exam. And there are almost 6,000 views so far on our YouTube channel for various lectures on aeroanatomy. We hope to reach as many students as possible who can take maximum benefit out of this. Vidya Nama Narasya Rupamadikam Prachanaguptam Dhanam. We have seen the inability of common students to afford huge amounts on commercial study platforms, despite their jignasa, that is, that burning desire to learn. Jignasa is here to give a helping hand, learn anatomy with experts, and all we need is your immense interest to learn. Today, we have Dr. Alka Jayavant Kumar, Professor and HOD of Rachana Sharira, JSSA AMC Mysore. Ma'am has completed his studies in Government Ayurveda College, Nanded, Maharashtra, and has teaching experience of 24 years. Ma'am, we welcome you to the session and to each and everyone who is watching this. We hope you find it useful, helpful. Thank you. And now I request Dr. Alka ma'am to carry on forward with the session.
Thank
Ma'am.
you. Thank you very much. And just good afternoon, everyone, my children. And thank you for this Jignasa Foundation for giving me this opportunity. And I will go to start my session. Good afternoon, everybody. And today's my topic is male reproductive system. So I will make it easy. And if any doubts are there, you can tell me afterwards. No problem. So male reproductive system. See carefully. These are containing male genital organs. These are situated in the pelvic cavity, that means both outside the pelvic cavity as well as within the pelvic cavity. So, out of these, some organs they are situated out of the pelvic cavity. These are penis, scrotum, testis, epididymis, and spermatic cords. Especially, we have to see that testes are there, which are the male gonads, and they cannot tolerate body temperature. If they are going to situated in the pelvis, then the spermatozoa they are going to destroy. That's why this is the natural adjustment is there. So these structures they are present outside our body. So inside our body, another organs are there, just like vas deferens is there, prostate is there, seminal vesicle, barbourethral glands. So all these structures which are present inside the body. First one structure which is known as first one organ is there, that is penis. So see carefully, the penis organ, it is nothing but here, this is the male organ of copulation. Just like in female, vagina is the organ of copulation. In male, organ of copulation is male. It is made up of two parts, that is, one is root, another is body. Root is the fixed portion, which is attached portion is there, and body, it is the free portion. The that means these two structures are there. So root of penis, it is nothing but here, it is situated in superficial perineal pouch. You are knowing perineum, it is the structure or the part which is present in between anus and the urethra. So in that one, superficial and deep perineal pouch are there. So this root of penis, it is situated in the, that means superficial perineal pouch. It is composed of three erectile masses tissues, and these are known as two crura and one bulb. Singular is crus, plural number is clura. Each crus is here, see carefully, each crus it is firmly attached to this nothing but here, uh, each crus it is attached to this perineum, that means the pubic arch. You studied all this, that means parts, because your batch is exam going batch. So you should know this pubic arch is the part, or it is nothing but a part of hip bone. The two ischiopubic rami, when they are joined with each other, they are forming, their lower border is forming the pubic arch. So to this pubic arch, fascia lata is attached, as well as collis fascia is attached. So here, this is nothing but it is attached to the pubic arch, and it is covered by ischio-cavernous muscle. The bulb of penis, it is the median part, it is attached to the perineal membrane in between two crura. Means remember that root of the penis, it is formed by two crura and one bulb. Each crus is attached to this nothing but pubic arch and covered by ischio-cavernosus muscle. The bulb is present in between two crura, and it is attached to the perineal membrane. It is covered by bulbospongiosus muscle. Its deep structure, the difference in between these two is the deep structure of bulb of penis, it is pierced by urethra. The crus of penis never pierced by urethra. And this traverses, that means throughout the substance, the urethra traverses. This part of urethra within the bulb, here, the one part is there which shows dilatation, that is known as infundibular navicular fossa. In exam, penis is coming for 5 marks. If you are remembering, you can write down. Otherwise, simply write down root of penis. It is formed by two structures, two parts, crura, two crura, and one bulb. Two crura, these are, that means the erectile masses tissues. Each crus is attached to the pubic arch and it is covered by ischiocavernosus muscle. In between these two crura, bulb is there, and this bulb, it is nothing but attached to the perineal membrane and it is covered by bulbospongiosus muscle, as well as it is traversed by urethra. This much is explanation of root of penis. As per points, you have to write in exam, then you will get full marks. Next part of penis is there, that is body of penis. A free portion of penis is completely enveloped by skin. So this is the free portion is there, which is completely covered by the skin. It's next, it is, see carefully, body of penis, which is completely covered by skin and it is continuous with root in front of the lower part of pubic symphysis. Pubic symphysis, you are knowing, these are the, that means joint in between the medial surface or symphysial surface of the two pubic bones at the median line of our body. So it is continuous with the root in front of lower part of pubic, that means symphysis. And it contains nothing but here, that means here, see carefully, its ventral surface directed backwards and downwards, dorsal surface directed forwards and upwards. The penis, it is composed of three elongated masses of erectile tissues. These are two corpora cavernosa and one corpus spongiosum. The corpora cavernosa, these are, that means these, during erection of penis, you should remember that these three erectile tissues, they are engorged with blood. These are, that means two corpora cavernosa, right and left, and median one is corpus spongiosum. So here, each corpus, that means cavernosum, these are, that means these are the forward continuation of the crura. They are in close opposition with each other. You have to remember, mostly you dissected this part, you have dissected. So at that time, we have to see that how parallelly this body of penis in that corpora cavernosa are running, and median plane there is corpus spongiosum is there. If you are taking TS of this penis, as per book picture, the picture you can see. So each of them terminates under cover of glans penis, means while running they will parallel with each other and they are not going to continuous up to glans penis. Just before that, that means they are terminates under the cover of glans penis, in that is which is a blunt conical extremity. They are surrounded by strong fibrous capsule, that is fibrous envelope, that is known as tunica albuginea. So the tunica albuginea, which is having fibers which are longitudinal fibers are there. So it enclose this corpus, that means corpora cavernosa. So you should remember that the two corpora cavernosa, which are the two erectile masses, and they are running parallel with each other, but they are not continuous up to glans penis. Instead of that, they terminates under cover of glans penis in a blunt conical extremity. They are surrounded by strong fibrous envelope or tissues which are having longitudinal fibers. These are known as tunica albuginea. So next is corpus spongiosum. So corpus spongiosum, which is nothing but just I told you root of penis, in that bulbous spongiosum. So here bulb I told you. So this is the forward continuation of bulb of penis. Its terminal part is expanded in a conical enlargement that is known as glans penis. Throughout its whole length, it is traversed by urethra, and just like corpora cavernosa, it is also surrounded by fibrous sheath. The here, so the base of glans penis has a projecting margin that is known as corona glandis. It overhangs an obliquely grooved constriction. Always you remember that constriction part is known as neck. So here also one constricted part is there just below this glans penis, that is known as neck of penis. And within the glans, the urethra shows a dilatation that is known as navicular fossa. So if we are taking section at the time of dissection of the penis, tiers of penis, in that, see carefully, you can show this section where parallelly running two corpora cavernosa are there, and here below that you can see the rounded structure that is corpus spongiosum, but there is no any hole in the corpora cavernosa because it does not get traversed by urethra. But corpus spongiosum, it is going to, that means traversed by urethra. That is the speciality of these three erectile masses. These are the spongy tissues are there which are going to fill with blood at the time of erection of the penis, or at the time of ejaculation, erection of penis. At that time blood is going to fill here. So this is nothing but the root of penis as well as body of penis. Next, here, this is the section. Same picture is coming if we are taking this tiers of the penis. Along with that, you should see the supports of the body of penis. So this penis free portion is there, and every free portion, it needs supports. So here two supports are there. One is fundiform ligament, another is suspensory ligament. You should remember that this question may be asked for MCQs. What are the supports of the penis? So they can give any one ligaments name that are either belongs to liver or bladder or uterus, anyone, and they will give this fundiform ligament, suspensory ligament. So ovarian ligaments are there. So they will do the mixture of all these and they will ask question in MCQs. So two supports are there for the penis, fundiform ligament and suspensory ligament. Fundiform ligament extend downwards from the linea alba and splits to enclose the penis. It lies superficial to the suspensory ligament. Suspensory ligament lies deep to fundiform ligament and extends from pubic symphysis and blends below with the fascia on each side of pelvis, that means penis. Here, arterial supply to the penis, this is nothing but internal pudendal artery, three branches which supply deep artery of penis, then here which runs in the corpus cavernosum. It breaks up into the arteries. This is very much important, that follow a spiral course, and that's why they are known as helicine arteries. These helicine arteries are going to feel and they are going to engorge at the time of erection of penis. Dorsal artery of penis, glans penis, and the distal part of corpus spongiosum, prepuce, that is the skin over the glans penis. I told you, clonic, that means conical, part. I told you that's nothing but the glans penis, which is the part, that is the end part is there, and it is skin covering. It is very thin and dark in color. It is loosely connected with the facial sheath and it can retract backwards. So that skin is known as prepuce. So it is supplied to the prepuce and frenulum. The artery of bulb and the proximal half of the corpus spongiosum, see carefully, distal part is supplied by the dorsal artery and proximal part it is supplied by artery of bulb. So the along with that, the femoral artery is superficial external pudendal artery which is going to skin and fascia of the penis. You had seen at the time of dissection, in the superficial dissection of the anterior compartment of thigh region, when we are going to open the femoral triangle, we will see the three superficial branches of femoral artery. In that, one is superficial external pudendal artery, superficial epigastric artery, and that is nothing but, so out of that the superficial external pudendal artery, which is going to nothing but third one is superficial circumflex iliac artery, but the superficial external pudendal artery, which is going to skin and fasciae over the external genital organs, so that it is going to supply to the skin and fasciae over the penis. By minute dissection, we can see these three arteries, and next three deep arteries of the femoral arteries are there. So these are the arterial supply, which is very much important, because erection of penis in that phenomena, these arteries, the blood, majority of blood is coming there. Venous drainage, superficial dorsal vein, that is which drain into, that means superficial external pudendal vein, and deep dorsal vein, prostatic plexus of vein. Lymphatic drainage is superficial, it is very easy to remember, superficial inguinal lymph nodes and deep inguinal lymph nodes. Nerve supply, sensory nerve supply, that is dorsal nerve of penis and ilioinguinal nerve. Muscles, perineal branch of pudendal nerve. Autonomic nerve supplies pelvic plexus via prostatic plexus. So this is about penis, and you remember, my all the students, that penis is in exam always coming for 5 marks. For each and every part I will tell you which questions will going. So most probably it will not ask for 10 marks, but 5 marks it will come. That the small questions, MCQs, will come, just like I told you, the fundiform ligament or the three erectile masses tissues, they will ask the name. So in that way MCQs will come. Next part is there, that is scrotum. So see carefully, the scrotum, it is a cutaneous bag which containing left and right testes, epididymis, and lower parts of spermatic cord. So see carefully, simply it is there. This is just like bag which contains testes is there. Just above the testes, one comma shaped structure is there, that is epididymis, and the lower part of spermatic cord. So it encloses these portions, and externally the scrotum is divided into right and left parts by a ridge or by a median raphe, which is continuous forwards onto the undersurface of penis and backwards along the middle part of the perineum to the anus. Here you should remember that the scrotum is divided into right and left parts only externally. Remember this, not internally. It is never going to, that means divide internally, it is going to divide internally in only hermaphrodite persons. So next is, see, this is the picture of the scrotum. The left half of scrotum hangs a little lower than the right, in corresponds with left, that means spermatic cord is having greater length than the right. Here another one thing is most important is there, that is under the influence of cold, the condition of the scrotum, how it is going to change means, in young and these healthy persons, the scrotum is short and it is very firm and closely applied to the testes. Under the influence of warmth, and in old and debilitated, means those who are very weak persons, they are, along with having chronic diseases and very weak general weakness, debilitated means generally weakness is there. So in such type of person, the scrotum is elongated and flaccid, and this is nothing but, under that means it is formed by during that means due to the relax the scrotum, it is relaxed in this debilitated person due to relaxation of the dartos muscle, and it is stiff and very strong, as well as it is short, closely applied to the testes. It is short in the young healthy persons, that is due to contraction of the dartos muscle. So this muscle is nothing but most important in regulation of temperature within the scrotum. So these are the layers. This is also, it will come for nothing but MCQs. The layers of the scrotum are outermost skin, then dartos muscle, which is instead of the superficial fascia, then external spermatic fascia, cremaster, cremaster muscle, cremastric fascia, and internal spermatic fascia. Either you can write down cremaster muscle or you can write down cremastric fascia. So these are the layers: skin, dartos muscle, external spermatic fascia, cremasteric fascia, and internal spermatic fascia. So, blood supply to the scrotum, it is by following arteries: superficial external pudendal artery, deep external pudendal artery, scrotal branches of the internal pudendal artery, cremasteric branches of inferior epigastric artery. Next, we have to see nerve supply, which is very, very important in the scrotum. Anterior one third of the scrotum is supplied by L1 spinal segment, that is ilioinguinal nerve, and genital branch of genitofemoral nerve. Posterior two-third of scrotum, it is supplied by segment S3, that is nothing but here posterior segment supplied by S3, segment of spinal cord through the posterior scrotal branches of pudendal nerve and the perineal branch of the posterior cutaneous nerve of the thigh region. So see carefully in this nerve supply, we have to see one thing or we have to observe one thing, means anterior one third is supplied by L1 while posterior two third is supplied by S3. So that much distance is there in between spinal segment. After L1, L2, L3, L4, L5 and then S1, S2 is there. So one is supplied by anterior one third is supplied by L1 and posterior two third is supplied by S3, so that any surgery on the scrotum at that time is very difficult to give spinal anesthesia. Dartos muscle is supplied by genital branch of genitofemoral nerve. So this is about this, nothing but the what we called as nerve supply to this scrotum. For clear anatomy, here you should remember that due to laxity of skin, here skin is very lax and hanging or dependent position of the scrotum, it is very common site for edema, and due to presence of abundant hairs as well as sebaceous glands, it is also a common site for sebaceous cyst. It is also, that means in this is another one thing is there. I told you L1 and S3, it is very difficult to give spinal anesthesia. I also told you that is the scrotum, it is bifid internally. Internally, it is divided in pseudo-hermaphrodite. Pseudo-hermaphrodite and true hermaphrodite, these are the types of intersex persons. In pseudo-hermaphrodite, that means scrotum is bifid in nature, and in this case, that means in true hermaphrodite, both the gonads are present. That means testes are present as well as ovaries are present. But in pseudohermaphrodite, the internal, that means the gonads are of male if then external genital organs are become female. And if that means internal, vice versa, if internal are male, external will be female. So one is gonad from one sex and external genital organs belongs to another sex. So this is nothing but the characters of the pseudohermaphrodite. Hydrocele, next, it is a condition in which fluid accumulates in the processus vaginalis, and here the types of hydroceles are there. So many types are there, and some abnormal scrotal contents sometimes they may be present. So here and in this hydrocele, they are going to tapping the fluid and they are making the processus vaginalis or the vaginalis layer, they becomes reflect or they becomes make it ulta, and then they are going to stitch that. So never next again accumulation of fluid is going on. So this is most important. Scrotum also will come for 5 marks, and some, this is the condition, I have hydrocele, and next sometimes that means it may become for this MCQ, just like in scrotum, that means this temperature regulation, it is performed by dash muscle. So any one topic it in MCQs, we can't predict any questions, but previously 3 marks, 2 marks questions were there at that time. Sometimes scrotum may ask for 3 marks, or sometimes layers of scrotum they may ask for 3 marks, but now total scrotum also it may come for 5 marks. Next topic, most important, that is testis. So testis is coming for 10 marks in exam, or sometimes they may give for 5 marks. So here you should remember that testes are male gonads. It is homologous with the ovaries in the female. So it is suspended in the scrotum by spermatic cord. The testis is oval in shape and is compressed from side to side, 3.75 centimeter long, 2.5 centimeter broad, 1.8 centimeter thick, weighs about 10 to 15 grams. Two poles are there for its anatomical structure explanation: upper pole, lower pole. Upper pole is smooth and convex and it provides attachment to spermatic cord, and two borders: anterior border, which is convex and smooth, fully covered by tunica vaginalis. Posterior border is straight and it is partially covered by tunica vaginalis. Epididymis lies along the posterior border. Two surfaces are there, that means medial surface and lateral surface, which are convex and smooth. These pictures you have to make perfect yourself because you have to write these. Coverings of testes: outermost tough layer, that is the outermost layer, which is known as tunica vaginalis, and which presents the lower persistent portion of processus vaginalis. It is invaginated by testes and it has parietal and visceral layer. It covers the whole testis except for its posterior border. Tunica albuginea. So tunica vaginalis, it is nothing but having two layers, parietal layer and visceral layer. Tunica albuginea, it is a dense bluish white covering layer of or covering of the testes, which is composed of interlacking bundles of collagen. At the posterior border of testis is projects into the testicular interior as a thick, incomplete fibrous septum. Straight septum is there, that is known as mediastinum testis, through which testicular vessels run. And innermost coating or innermost covering, it is vascular layer, that is known as highly vascular tunica vasculosa. It covers testicular lobules and it contains a plexus of blood vessels and delicate loose connective tissue. Structure of the testes. So here each testis, the glandular part of testis, each testis is subdivided into lobules, and these are 200 to 300 lobules. Each lobule contains nothing but 2 to 3 seminiferous tubules, and each tubule, it is highly coiled on itself. When stretched out, each tubule measures about 60 centimeter in length and zero point 0.2 centimeter in diameter. The tubules are lined by the cells, which represents the stages in the formation of spermatozoa. The seminiferous tubules join together at the apices of the lobules to form 20 to 30 straight tubules, which enter the mediastinum. This structure of testes is very much important in the view of exam. You have to read it, you have to by heart it. Here they anastomose with each other to form a network of tubules that is known as rete testis. In turn, the rete testis give rise to 12 to 30 efferent ductules. See in picture it is there. So here, these are the seminiferous tubules. Then there is the network-like structure, rete testis, and then there are efferent tubules are there. So these are efferent ductules which emerge near the upper pole of testis and enter the epididymis. So see carefully. This is posteriorly mediastinum is there, and that are this is the head of the epididymis. In between that, you can see the network-like structure, that is rete testis. Then there are 20 to 30 efferent ductules, and they are entering in the head of the epididymis, where they are going to form the head of the epididymis. Here, arterial supply, the testicular artery, which is a direct branch of abdominal aorta. The veins emerging from the testis, that is form pampiniform venous plexus, and these veins which accompany testicular artery, and they are going to drain into right side inferior vena cava and left renal vein. Preaortic and para-aortic, these are the lymph nodes, and the testis is supplied by sympathetic nerves arising from segment T10 of the spinal cord. This is the venous drainage, and this is the histology. Now, histology added to your syllabus. So sometimes in when it is coming for 10 marks, you have to write along with that in spot. That means in the practical exam, you are having 100 marks writing in that. One topic is there, that is histology. So you should be prepared for histology of testes, histology of ovaries. So this is very much important. Clinical anatomy. Along with that, before that, you should see the testes, they are going to descend. At the time of fetal life, the testes are, first of all, they form in the lumbar region, and from where they are going to descend. Sorry, that slide is not there. So these testes, they start their descent, and they are going to descend and come out of the body. And next, they are going to take their position in the scrotum. So these testes develop in relation to the developing mesonephros at the level of segment T10 to T12. Subsequently, they descend to reach the scrotum, and they start their descent at the second month of intrauterine life. It reaches the iliac fossa at third month. Take rest at the deep inguinal ring from 4 to 6 months. Traverses the inguinal canal during 7 months, reaches the superficial inguinal ring by 8th month, and comes at the bottom of the scrotum by 9th month. And how this descent of testes is going on, so for this, whatever reasons are there, but that now also after tremendous research, exact what cause is there, that is not known. But some probable, they told that number one, differential growth of body wall, hormones including male sex hormone, as well as formation of the gubernaculum and intra-abdominal temperature and pressure. So these are the most important things are there which we have to see. As well as in the testes, you have to see that there are two types of cells are there. That number one is known as sertoli cells. These are tall and columnar, and these cells, they shape extending from the basal lamina, and they support and protect the developing germ cells and help in maturation of spermatozoa. Here, that means that, and along with that, they are nutrition and the maturation of spermatozoa, spermatogenesis, which is controlled by FSH of the anterior pituitary gland. Interstitial cells of Leydig, they are found as small clusters in between seminiferous tubules. They secrete testosterone or androgen, and the activity of Leydig cell, it is controlled by interstitial cell stimulating hormone of anterior pituitary gland. So next in this, that means the clinical anatomy is monarchism, means that one side testes are present and one side testes are absent. So only one side presence is there. Undescended testes, it is also known as cryptorchidism, means sometimes the testes are failed to descend in the scrotum, that is known as undescended testes. And here, if in premature birth, most probably undescended testes are there, or sometimes after full term also they are not going to, that means descend. So here that they can lie in between iliac region, inguinal region, lumbar region, but in 70% cases in premature delivery, afterwards that baby completing 9 months, then they are automatically coming downwards, but sometimes it may need surgical correction. Hermaphroditism, I told you true hermaphroditism and false. So here that things are there. So in false hermaphrodite, there are only one genital organs and another sex gonads are there. While true hermaphrodite, both the gonads are there, so that individual shows the features of the male as well as some of male and some features of female. The testes and epididymis may be the site of various infections and tumors. Testes may be palpated to check any nodules, and varicocele, it is that means produced by dilatation of, I told you, the venous plexus, pampiniform venous plexus. We can see very nicely at the time of dissection this pampiniform venous plexus. and the left side spermatic cord is longer, so that the varicose heel is generally can be observed towards majoritarily in the left side. So this is about the testes. Next is epididymis. So epididymis, it is nothing but a organ. It is exactly just like if we are going to see, it is a comma shaped structure, and here it is highly coiled tube, and that acts as reservoir of spermatozoa. You remember that in the testes, spermatozoa are going to form, and they are going to preserve, or they are going to store in the epididymis. It contains three parts: head, body, and tail. Efferent ductules, which are coming from these testes, they are enter in the epididymis, and they are forming this head of the epididymis. So in this duct, muscle is thicker and undergoes peristaltic contractions to propel the spermatozoa in the tail region. It is a site of maturation of sperms and storage place of the sperm. Next here, along with that, the head, it is formed by nothing but here the efferent ductules, and after that the single duct, that is ductus epididymis, is going to form, which is highly coiled. It forms the body of the epididymis, and next it forms the tail of the epididymis, and afterwards it becomes straight, and that is continuous as ductus deferens. Vessels and nerves, testicular artery, and nerve, that means venous drainage and lymphatic drainage similar to testes. Sympathetic nerves through the testicular plexus. Clinical anatomy, here inflammation to the epididymis, it is also known as epididymitis, and inflammation to testes as well as epididymis, it is known as epididymo-orchiditis. So here this is about this epididymis. Next is spermatic cord, which is a cord-like structure, and it starts from the posterior aspect or posterior border of the testes and ascend upwards, and then it traverses to the inguinal canal. So here the constituents or the structures which are present in the spermatic cord are ductus deferens, testicular arteries, cremasteric arteries, artery of the ductus deferens, pampiniform venous plexus, lymph vessels, genital branch of genital femoral nerve, plexus of sympathetic nerves, and remains of the processus vaginalis. This is the transverse section through this spermatic cord, and here in the spermatic cord we can feel the vas deferens just like rod-like structure. From within outwards, the coverings of spermatic cord are internal spermatic fascia, which is a fascia transversalis. It covers the cord in its whole extent. Cremasteric fascia, it is made up of muscle loops constituting cremaster muscle, and external spermatic fascia, which derived from the external oblique aponeurosis. It covers the cord below the superficial inguinal ring. So these are nothing but this spermatic cord pictures are there. Next are male internal genital organs. So in that, most here important is vas deferens. It is coming for 5 marks, my students. So see carefully. It is also known as vas deferens, ductus deferens, or different duct. Any one name they will give in exam. So don't confuse it. It is a thick-walled muscular tube which transmits spermatozoa from the epididymis to the ejaculatory duct. It is narrow lumen, and here it contains narrow lumen except at the terminal dilated part. Generally, most of these structures are there in anatomy. Wherever dilated part is there, that is known as ampulla. So just like in fallopian tube, you had seen ampulla, as well as another one you can see in the semicircular canals of the internal ear. There also ampulla is there. So wherever dilated part, you should remember that is ampulla. Length of this vas deferens, it is 45 centimeter long, and you should remember that it will come as MCQs. So next we have to see location. In its course, the vas deferens lies successively, means it pass through the four, that means parts, in that within the scrotum. Its first course is within the scrotum along the posterior border of testis. Next, it traverses the inguinal canal as the part of spermatic cord. Third one in the greater pelvis, next in the lesser pelvis. If we are doing keen dissection, neat dissection, we can get the course of this vast difference also. So here, course and relations, the ductus difference begins as a continuation of, I told you, tail of epididymis. Along the posterior border of testes, it becomes tortuous, gradually strengthens as it ascends along the posterior border of testes, medial to the epididymis. Here, in the spermatic cord, it lies vertically in posterior part of spermatic cord. It runs upwards to the superficial inguinal ring and traverses the inguinal canal. That's why it is very much important. So in the inguinal canal, it traverses, and in the spermatic cord, I told you, if we are palpating, we can get the rod-like structure externally also, and we can assess that which is the nothing but vast difference, and there only the doctors they are going to do the vasectomy. Next, it enters in the inguinal canal at the deep inguinal ring. It traverses from superficial inguinal ring to deep inguinal ring, and when it comes to the deep inguinal ring, it leaves the spermatic cord and then it hooks around the lateral side of inferior epigastric artery. I told you in the dissection we can see how it is going to hook the inferior epigastric artery. It then passes backwards and medially across the external iliac vessels. In lesser pelvis, when it enters through the brim of pelvis, it runs downwards and backwards on the lateral pelvic wall, deep to the perineum. I told you at the time of dissection, you have to keep the book along with you and read, and remaining students should do the dissection. Then you will get exact this course. Here it crosses obliterated umbilical artery, obturator nerve vessels, and vesical vessels. It then crosses ureter and bends medially at right angles to enter the sacrogenital fold of peritoneum. So here, see, this is the total, that means course of the here vast difference. And next, see carefully here, afterwards it joins with the that means the duct of the seminal vesicle to form ejaculatory duct. Blood supply artery to the ductus deferens arises from terminal branches of the one of the branches of the superior vesical artery and veins drain into vesical venous plexus. Clinical anatomy here, vasectomy is there. That's very much important. See carefully here. So vasectomy, it is nothing but the male sterilization surgery. It is nothing but the male sterilization is there, in which they are going to, that means cut this what we called as testes, because you have to remember that the testes they are going to transfer or they are going to conduct the spermatozoa. It is a minor operation which is done under local anesthesia. A median incision is made up on the upper part of scrotum and just below the penis. Through this incision, both the different ducts get operated and a short segment of each is excised. So, the vasectomy and tubectomy, both procedures are same, but as compared to tubectomy, vasectomy is very easy. So, in picture they shown such type of that the one piece of either side of vas difference it is going to cut, they are going to cut, and the ends they are going to ligate it, because if ends are not ligated as per natural phenomena, these two ends they are going to join with each other and again the tube will be patent. So either vasectomy or tubectomy, these both the procedures they are reversible procedures. That means tubectomy, it is to cut the tube, fallopian tube. Tuboplasty means again joining the tube. Similarly, vasectomy also here they are going to cut, but afterwards, if that patient wants, there is reversible action is there. They have to go to do this. That means tuboplasty or the plastic surgery for this vas difference. But see carefully, for cutting the tube, 5 minutes are sufficient. But for plastic surgery or joining, it will take hours. So at least hour. So always for formation or construction, it will take much more time than the destruction. So here, after vasectomy, the testis continues to produce hormones. Normally, that one doubt is there always, to maintain the male characteristics. The hormones pass out through the veins. Sperms are present in the ejaculation after vasectomy for 2 to 3 months, as it is an emptying procedure. See carefully, after vasectomy, they are going to cut, but whatever spermatozoa they are there, because it is a emptying procedure, so that 2 to 3 months spermatozoa they are going to ejaculate. Newly formed sperms are destroyed after vasectomy. In the epididymis itself, how the epididymis, it is a reservoir is there, in that senile spermatozoa they are going to destroy there. So similarly, after vasectomy, the sperms they are going to destroy, and they are going to remove by phagocytosis. Next, here seminal vesicles. These are two small pouches or lobulated sacs are there, situated between the bladder and the rectum. So each vesicle is about 5 centimeter long, directed upwards and laterally. The lower narrow end forms duct of seminal vesicle. It joins difference to form ejaculatory duct. The seminal vesicle do not form or do not performs the function of reservoir for spermatozoa. Their secretion forms a large part of seminal fluid. Bulk of seminal fluid, it is formed by seminal vesicles. The secretion is slightly alkaline and contains fructose and coagulating enzyme called vesiculase. So these are the picture of seminal vesicles. Ejaculatory duct, see carefully, it is formed by the union of terminal parts of ductus deferens and the duct of seminal vesicles at the base of prostate gland. It opens into the prostatic part of urethra below, and each side of prostatic utricle carries seminal fluid into the urethra. Next part is prostate gland. So prostate gland, it's also coming for 5 marks. It is somewhat large part is there. It may come for 10 marks, but that is only possibilities there. It is an accessory gland of the male reproductive system. The secretion of this gland add bulk to the seminal fluid along with those of seminal vesicle and bulbourethral glands. Situation, see carefully, lies in the lesser pelvis. See, this whole situation one by one comma is there. In that way, you have to remember it is situated in the lesser pelvis, number one. Second, below the neck of urinary bladder. Third one, behind the lower part of pubic symphysis. And fourth one, upper part of behind the lower part of pubic symphysis and upper part of pubic arch. And last one, in front of ampulla of rectum. So these are the locations or site. That means total. That means where this prostate is located. So first one, remember, it is present in lesser pelvis. Where it is present in lesser pelvis? Just below the neck of urinary bladder, behind the lower part of pubic symphysis and upper part of pubic arch, and in front of ampulla of rectum. Shape and size and weight, it resembles an inverted cone measuring about 4 centimeter transversely at the base, as measuring about 4 centimeter transversely, that is the width is there, and 3 centimeter, that is the length, and 2 centimeter posteriorly, that is thickness. So length is 3 centimeter, width is 4 centimeter, and thickness is 2 centimeter. So this is one of the organs in our body which is having more width than the length. Remaining organs, you are knowing, pons is there, pituitary gland is there. So you should remember this may come for MCQs. It weighs about 8 grams. Gross features are there: an apex directed downwards, a base, and 4 surfaces, anterior, posterior, and 2 inferolateral. Apex, it is directed downwards and rests on the surface of the urogenital diaphragm. It is separated from anal canal by perineal body. Next here, base directed upwards and is structurally continuous with the neck of the bladder. The junction is marked by a circular groove which lodges venules of vesicle and prostatic plexus. Remember that this organ is surrounded by dense venous plexus. Surfaces, anterior surface is narrow and convex from side to side. It lies 2 centimeter behind the pubic symphysis with retropubic fat. Intervening means place in between pubic symphysis and prostate. Its upper part is connected to the pubic bones by the puboprostatic ligament. Remember that in female, the puboprostatic ligament, it is replaced by pubovesical ligament. The lower end of this surface is pierced by urethra. This is most important. See, this is the picture. And next here, this is also, see, puboprost. That means the urethra, how it is traverses through this, nothing but prostate. Here, ejaculatory duct also there. Prostatic utricle is there as well as urethra is there. Next, you have to see posterior surface. It is triangular in shape. Posterior surface also very much important clinically. It is flattened from side to side and convex from above downwards. It is separated from the rectum by fascia of Denon-Wheelers. And near its upper border, it is pierced on each side of the median plane by the ejaculatory duct. This surface, this point is very much important in clinical aspect when you will enter in final year. At that time, you will come to know surgical anatomy of each and every organ you have to study. So there this point is very much important. This surface lies 4 centimeter from the anus and can be easily palpated on the digital examination through the rectum. Digital means by finger. Digits, fingers are known as anatomical terminology digits. So if we are passing our index finger in the rectum, that means through the anal canal, so at that time, that means per rectum exam, that is known as PR exam, through which only 4 centimeter distance is there. That means from the anus to the posterior surface of prostate, so that we can palpate the prostatic enlargement there. So see, this is the digital examination is there. That is upward part is rectum is there and below there is bladder is there. Same picture, same thing you can see in this, that means in the dissection. If we are taking pelvic section, so we can definitely see the difference in between male pelvis and female pelvis. In male pelvis, see only rectum and bladder is there. In female pelvis, in between these two, uterus will come. So rectovesical pouch is there, that is peritoneal pouch. And here, see below there is just near this at the neck of bladder, there is, you can see below the neck of bladder, there is prostate is there. So if we are passing the finger, we can get the prostatic enlargement. This is most important exam. The inferolateral surfaces are related to anterior fibers of levator animosal, which is most important in the formation of this, nothing but diaphragm, urogenital diaphragm. So they are separated from the muscle by plexus of veins embedded in its sheath. I told you this organ, it is surrounded by dense venous plexus, so that prostatectomy surgery in that profuse blood loss is there. This prostate, it is surrounded by zones. Only remember that there are, the zones are there. Peripheral zone, it is 70%, as well as here nothing but, that means central zone, it is 25%, and that means periurethral zone, it is 5%. So peripheral zone, which is formed by glandular tissue, as well as 25%, these are glandular tissues are there present posteriorly, central zone. And here central zone, that means does not involve in any diseases, but peripheral zone, which constitute the 70% part, that is vulnerable for this cancer. And periurethral zone, which is 5%. And here prostatic hyperplasia generally occurs in this zone. This is again, pictures are there, lot of pictures are there. See here that green, all are venules. And next lobes are there. Previous concept of this prostate, when I was teaching for starting 2001 to 3 batches at that time, In same books, Chauresia books only, they given that prostate has 5 lobes, anterior, posterior, median or middle lobe, and 2 left and right lateral lobes. But now they are telling that only median or middle lobe and right and left lateral lobes are there. So these are the lobes are there for this prostate. Capsules, the prostate is covered by true capsule and false capsule, and removing this capsule at the time of surgery, it's also very difficult. So see carefully, pubic symphysis in between retropubic space and fat of, that means pad of fat is there. That green color puboprostatic ligament is there. I told you in between rectum and urinary bladder, rectovesical pouch is there, and lower part perineal body is there where 10 muscles are going to insert. Then either side, that small lobular structure, seminal vesicle is there, and there is denonvillar fascia is there. So these are all the things are there. These are again pictures are there. Next, structures within the prostate. Prostate, it is traversed by prostatic urethra, prostatic utricle, and ejaculatory ducts also enter. Next, structural zones. The outer larger zone is composed by large branch glands, the ducts of which curve backwards and open mainly into prostatic sinuses. This zone is frequently the site of carcinoma. The inner small zone is composed of submucosal gland opening in the prostatic sinuses and a group of short simple mucosal glands which are going to surround the upper part of urethra. This zone is always prone for benign hypertrophy. So these are the zones of this prostate. Blood supply. The prostate is supplied by branches from the inferior vesical artery, middle rectal artery, and internal pudendal arteries. The veins form a rich plexus around the sides and base of the gland. The plexus communicates with the vesical plexus and with the internal pudendal vein and drains into vesical and internal iliac veins. Lymphatic drainage from the prostate gland drain chiefly into internal iliac lymph nodes and sacral lymph nodes, and partly into external iliac nodes. Nerve supply to the prostate, it is prostatic nervous plexus, which is derived from the lower part of inferior hypogastric plexus. Age changes are there in the prostate. These are nothing but at the birth. At the birth, the prostate is small in size and it is made up of mainly with stroma. At puberty, the male hormones, that is, bring about the rapid changes in the gland, and in about 1 year, it becomes double in its prepubertal size, and due to rapid growth of follicles, that means it is occur due to rapid growth of follicles and condensation and reduction of the stroma. From 20 to 30 years, there is marked proliferation and glandular of the glandular elements with infolding of the glandular epithelium into lumen of the follicles, making them irregular. From 30 to 45, the size of prostate remains constant, but involution starts. The epithelial infoldings gradually disappear and amyloid bodies increase in number. But most important changes occurs in the age after 45 to 50 years. The prostate is either enlarged, called benign hypertrophy, or reduced in size, called senile atrophy. And due to these only, most probably, the diseases are going to occur. Clinical anatomy, senile enlargement of the prostate. After 50 years, the prostate gland is often enlarged due to benign hypertrophy or due to formation of an adenoma. So here, this causes retention of urine due to distortion of the urethra. Enlargement of this median lobe not only projects into bladder but forms a sort of wall over its internal urethral orifice, so that the patient, if strains more for passing urine, more the urine is going to obstruct. Urine passes when the patient become relaxes, And at that time, the residual capacity of urine inside the bladder, it is going to increase, and that will reverse action will occur in the bladder. That walls of bladder becomes very much thick afterwards. Digital examination of the rectum is very helpful in the diagnosis of prostatic enlargement. Removal of such prostate, called prostatectomy, relieves the urinary obstruction. During removal, the enlarged gland is in, that means exceeds, leaving behind both the capsules and venous plexus between them. It's a very difficult to remove. Along with that, next is, that is here, inflammation of prostate. It is known as, that is, prostatitis, and the prostate can be removed through bladder, that is known as transvesical removal of the prostate, through prostatic capsule, that is retropubic, through perineum and fascia of Denonville's perineal approach, and through urethra, which is a common procedure, that is known as TURP, means transurethral resection of prostate. Inflammation of prostate is known as prostatitis. It may be acute, means sudden, or chronic. Acute prostatitis is secondary in gonococcal arthritis, urethritis, and chronic prostatitis may be secondary or mainly by the tubercular infection of epididymis, seminal vesicle, and bladder. Different, that means benign prostatic hyperplasia occurs in periurethral zone. Carcinoma of prostate occurs in peripheral zone. So I told you the zones are there. Number one, peripheral zone, which is 70%, central zone 25%, and 5% zone, that is nothing but periurethral zone. So both are peri. One is peripheral zone, that is 70%, that is mostly prone for carcinoma, while benign hypertrophy always occur in the periurethral, that means transition zone, but central zone not involved in disease. So prostate is the common site for carcinoma. It usually occurs after the age of 50 to 55 years, and in addition to urinary obstruction, it causes pain in perineum. The previous slide I told you, that is veins form a rich plexus around the sides of and base of the gland. The plexus communicates with the vesical plexus and with the internal portal vein and drains into vesicle and internal iliac veins. This is very much important part is there in prostate gland. When in final year you are going to read this surgical anatomy, this is most important part, because you should remember that wall-less connection is there in the venous drainage. Wall-less connection is there, and that connection is most important in clinically. So here the prostate is common site of carcinoma. It usually occurs after the age of 50 to 55 years. In addition to urinary obstruction, it causes pain in perineum, low backache, or sciatica. Rectal examination reveals an irregular, hard, and fixed prostate. Metastatic spread occurs to the, because due to, that means wall-less connection, it is going to transfer into vertebral column through the wall-less connections. Especially it is going to, metastasis are going to sacrum and between the prostatic and vertebral venous plexuses. And afterwards, this infection, it can be spread to the sacrum, to the vertebral column, and you are knowing in the vertebral canal spinal cord is there. So through that it can reach to the skull, and it can pass to the brain also. So this is very dangerous thing is there. So totally male reproductive system, it contains outer structures as well as inner structures. So you should remember that in the penis, this first one I told you, whatever I told this, you should remember these structures. See carefully. Here, first one I told you in my first slide. Penis will come for 5 marks, scrotum will come for 5 marks, testes will come for 5 marks, and spermatic cord also may come for 5 marks. Epididymis and all, they will nothing but come for MCQs. Next, for all these structures are there, inner structures, you should remember this ductus deferens, and that means prostate gland. These are coming for 5 marks. Testes, it will come for 5 marks or may come for 10 marks also. And remaining questions mainly are coming for MCQs, just like length and all dimensions and all these things are there. So be ready for this male reproductive system. Don't lose any one single mark also from this. If you are having any doubts, you can share with me. So thank you one and all.
Thank you, ma'am. Thank you for such a long session and for dealing all aspects of male reproductive system. Ma'am,
Yes.
can you turn on the camera now, ma'am, for interaction?
Huh? Yeah. What you call? What you are telling?
Ma'am, camera
Huh?
for question
Camera.
and answer.
Camera. Okay. 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 1 minute. Vaibhavi? Vaibhavi? What Vaibhavi
Guys,
follow?
meanwhile, you can just start putting up your questions in the chat box, and I will be reading out that to ma'am, and ma'am will be answering those questions. If you have any doubts, start posting them in the chat box regarding exams or regarding the topic ma'am dealt with.
झालं थोडं कॅमेरा ऑन करायचं डिस्कशन
अजून किती वेळ बघा,
झालं,
40
झालं.
झाले
हा, झालं, झालं.
झालं. बोल.
ते कपडे काढा म्हणा त्याच्यावरचे
बोल.
ते कपडे काढा म्हणा दरवाजावरचे. हॅलो.
Yes, ma'am.
हा. येस.
Uh, ma'am, we have
You
our
can.
first question
हा.
from a student named Gurraj.
हा.
Is
येस.
asking revised blueprint for RGHS for anatomy. Is
रिवाइज्ड
asking regarding the blueprint for question paper, ma'am, anatomy question paper.
क्वेश्चन. Okay, okay. That is nothing but 10 marks, 4 questions are there.
Yeah, ma'am.
Ha, so that is total 40 marks. 5 marks
Yes, ma'am.
questions are 8 questions, and 20 questions are MCQs. So 40 plus 40 plus 20. Okay. Hello.
Thank you, ma'am.
Ha, yes.
Yes, ma'am. Thank you.
Ha.
Yes, ma'am. Thank you, ma'am. Thanks for the answer, ma'am.
Okay. Okay.
There's another question from Fatima. She's
Ha.
asking regarding can we get the PDF format of this lecture?
PDF means what we called as PPT. PPT I have to say.
Yes, ma'am. Yes,
Okay, I
ma'am.
will
Yes,
send. I will
ma'am.
send to you.
They're
I
asking
will
for the
send to
PPT.
you. Okay, I will send to you. No problem. Huh?
Okay.
You can circulate.
Thanks, ma'am. Thank you, so much.
I don't know
Yeah,
how to
ma'am. Thank
circulate. I
you.
will send to you. Okay.
Yes,
If
ma'am.
any
Yes, ma'am. It's
any
perfectly
doubt
fine.
is there, you can share my number. They can contact me personally. No problem.
Yes, ma'am.
No problem. No problem,
Okay,
beta.
ma'am. Okay, ma'am.
Okay. Thank you
And
very
if
much for
this
giving
is
me
sent to us
opportunity.
on our Instagram or WhatsApp,
Which one? This one I will send in WhatsApp to you.
ma'am,
PPT.
yes, ma'am. If they send to us questions in WhatsApp or Instagram,
Yeah.
I will just
Yes,
forward
yes.
it to you, ma'am.
Yeah. You forward me. Otherwise,
Okay.
by phone call also, they can talk with me. No problem. Not only this,
Okay, ma'am.
regarding anyone,
Okay.
exam pattern or anyone their doubts, no problem.
Yes,
For
ma'am.
any topic, not only male reproductive, any topic. If they are having any doubts, tell them to ask me. I'm
Yes,
always
ma'am.
ready for that. Okay. And thanks to you also,
Okay, ma'am.
Karthik, also your Jignasa Foundation for
Ma'am,
giving me this opportunity. Yes.
ma'am, there's still few questions, ma'am.
Which one?
Ma'am, there's
questions.
still few questions from the students, ma'am. Shall I read it out, ma'am?
Yeah. Tell me. Huh,
The student named Pratiksha, she's
huh.
asking, should we learn the histology aspect of male reproductive system?
Testes only. Testes.
Okay,
Because we can't say na this time pattern is changed. So histology also contains marks in your practical. So in
okay,
preparatory
ma'am.
exam we had given histology of one organ to one batch. So in that
Okay,
yesterday's our last batch was there, so I given testes bar ovaries. So I told to students, so you have to learn the histology of actually major gross organs, just like stomach, small intestine, large intestine, duodenum, liver, pancreas, spleen, kidneys, as well as testes, ovaries. So in all
okay,
colleges, I asked, they are telling at least we should prepare 10 histological slides, or at least the teachers, they should circulate the histology pictures. And because who will come, we are not knowing, external examiner. And simply we will
yes,
lose
ma'am.
our 5 or 10 marks. Okay. Huh.
Okay, ma'am. Thank you, ma'am.
Okay.
This next question from Pratyush, ma'am.
Huh.
He's asking about should we write about hormonal actions if testis is asked?
No need. In anatomy, you only write that which hormone it is going to secrete. Because this is anatomy, you should write structure more. If in physio it is coming, you should write hormonal action. There is no need of hormonal action and all these things to write in anatomy. More than that, you write down the zones, capsule, lobes, surfaces, all these things. That's most important.
Thank you, ma'am.
Hmm.
There's actually a question regarding exam.
Huh.
The student is asking the exam, will it get postponed? I think it's a no, right,
No,
ma'am?
no, no,
The
no, no, no,
exam.
no, no. And why they should postpone? No need. As early as possible, if it is going to happen, na, they will read.
Yes,
Otherwise,
ma'am.
their educational life is going to extend. Because when it is going to happen, also we are reading that much only. See, if 15
Yes,
days
ma'am.
or 10 days it is going to extend, means they will be relaxed once again. Uh,
Yes,
and
ma'am.
and we have to face na, at any time we are going to face. So today either it is there or tomorrow, no change. We have to face
Yes, ma'am.
whatever it may. Don't be afraid
It
of this
actually,
exam. Don't be panic. Nothing is there.
yes, ma'am.
Take.
Actually, it really happened for our batch, ma'am. In first year also, our papers
Huh.
got postponed, and
Okay,
second
okay.
year
No, no.
also our
Sometimes
exams got postponed.
RGHS we
To our
can't predict anything sometimes. But to see,
yes,
for
ma'am.
my all children, I am telling you, exam is not at all a big thing. That's my common message to all the students, that your exam will start mainly when you will take your degree in your hand. After 5.5 years, your real exam will start. These university exams are not a big thing. You do one thing, that for 5 marks, you at any cost you should fill 3 pages. For 5 marks, you draw two to two figures, minimum two figures, and for 10 marks, draw 3 to 4 figures, and at least 6 pages you have to leave, but 5 pages at least you have to complete. If you are having less material, you completely fill the page with big diagram. And here you have to fill the pages, though your material in your brain it is less, but elaborate that question. Simply one example I will tell you, that is upper end of tibia is there, attachments. So intercondylar area, you should write there in one line, you can write down, that is anterior horn of medial meniscus, anterior horn of lateral meniscus, and anterior cruciate ligament. Then posterior horn of medial meniscus, posterior horn of lateral meniscus, posterior cruciate ligament. You can write down anterior, medial, everything, anterior, but don't write. You write down one below one. So what will happen? You can fill 6 lines. So in this way, you elaborate your answer and make the evaluator get impressed. Nobody is going to read each and every word, each and every sentence, because you are writing for 3 hours and they are going to evaluate within 5 minutes. So only your page is neatly filled or not, that impression is very much important. So writing in exam, it is a tact. Okay. Nobody is going to see how much it is there in your brain. That's the most important thing. So don't be panic. Don't be scared about exam. Nothing is there. Okay. Thank you. Next.
Thank you, ma'am. The
Uh,
next question is, can we have to explain clinical anatomy or naming it is enough?
no, 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 no. If it is coming for 5 marks and if their pages are remain, that is depend upon you. If you are already written all the things and if space is less, it is you can just mention. But if space is more, fill that space. Okay. Don't think about this one I have to write, that one I have to write. Don't become that much, that mentality you should not keep. You keep one mentality inside your brain that I have to fill the pages. What you are writing matter, that is not important. Only relevant matter you have to write. That's the thing. Okay.
Thank you so much, ma'am. I think the diagram aspects you explained, that was the frequent questions in all our sessions, ma'am. Everyone were asking about how to write diagram, when to write diagram, how many diagrams should we write for
No, no.
10
For
marks.
5 marks question, as per my knowledge, you should write 2 or 3 diagrams. You should draw neat, big diagrams. You should draw. And for
Yes, ma'am.
10 marks question, draw 4 5 diagrams as per needed. How many main diagrams are there? But some students are making mistakes. They are drawing small diagrams. No need that, because sometimes diagram will be more and explanation will be less. But whatever you are drawing diagrams, that should be neat. But don't go for what we called as shading and all these things. Only simply outline and labeling. Okay. But don't spend your time much more in that diagrams. You have to draw the diagram, but only outline should come. But that outline, it should be perfectly just like that organ. That for that purpose you have to try yourself, and diagrams should be always dark. So use dark pencil. First, you just draw with pen pencil, and after that, you dark it, because it has to scan. That's the most important part is there. Okay. Next.
Thank you, ma'am. Thank you so
Okay.
much. I think that's
Okay.
all from our question and answer session,
Okay.
ma'am.
Thank you, beta.
Really,
Thank you. Huh.
really, thank you so much, ma'am, from everyone at Jignasa on behalf of my whole organization and the whole
Okay.
team that's working for this first year students exam.
Huh.
Be it note series or lecture series, there's a whole team who are also students, second year, third year students who are
Okay.
acting,
Okay.
who are working despite their academic schedule to make this event successful. And
Okay.
I still remember the first conversation I had with you, ma'am, when I called and asked,
Okay.
gave
Okay.
you the details and asked about
Yes. Yes.
do
Okay.
this.
Okay. Huh.
You just said,
Huh.
better. I still remember that conversation, ma'am. You said, "Beta, don't worry, I will do." Uh, And
Huh.
you accepted in very first call itself, ma'am. And the second call I made was on yesterday, ma'am,
Yeah. Yeah.
to verify the proof with you, ma'am.
Yes.
Means,
Yes.
like I experienced, I met a person over a call just who is so down to earth, who comforted by saying, "Beta, I will do
Nothing is
anything
there.
for my students." Don't worry."
Nothing is there,
Also,
because
I told I will come to this, ma'am.
you come to Mysore and meet me. No problem. I come to Mysore.
Yes, ma'am. Yes, ma'am. I'm
See,
looking
in this
forward to that day, ma'am.
in this
Come and meet
world,
you personally.
lot of people are there, beta. We are not having level, actually. When we are seeing so much intelligent people, that time we will feel that we are nothing in this world. Okay. So, and that feeling should become in ours. If we are feeling us very superior, then we can't grow ourselves. It's not at all possible. We should always assume us as a zero, and from that we have to go. Then only these things are possible, otherwise not. Thank you, beta. Come to Mysore, okay, and
Yes,
meet me.
yes, ma'am.
Ha.
I'm looking forward to meet you, ma'am. That's
Yeah,
really
yeah.
great gesture from you, ma'am. That's a lesson to all of us who are pursuing, who are currently studying Ayurveda and who want to do something in our lives, to not to feel anything like we have did anything in life, because there's still so much to learn and there's still many
Yeah,
who are no who have the capabilities more than us, who have more
mm.
knowledge than us,
Yeah, yeah,
and
yeah.
that's the way we can learn, I guess, ma'am. And
Yeah.
that's really a great tip by you, ma'am. And I and my team will
Yeah.
try to include that in our lives, ma'am.
Okay, thank you very much. Thank you very much. And convey my thanks to all of your team. Okay. Thank you, beta. Huh?
Thank you, thank you,
Thank you.
ma'am.
Thank you.
Thank you
Thank
so
you.
much,
Thank
ma'am.
you. Okay, okay, okay.
And And student and everyone, thanks joining us for the session. We will
Yeah.
have a session in the evening too. And Spooty, we have arranged the video series for other subjects also, but it will be a single session. Unlike anatomy series, we have arranged topic wise anatomy sessions, but due to time constraints, we have arranged only one sessions from each subject. So join us in our community channel to get regular updates. Thank you guys for joining. So we will be ending our live session now.